ويسعدني طبعا وليا الشرف طبعا ان انا اقدم الاستاذه الجميله الفاضله الاستاذه الدكتوره ساميه نصر. طبعا والدكتوره ساميه يعني طبعا غنيه عن التعريف. ويعني حضرتك دكتوره هدى متولي كانت بتقول الصبح، بتقول لحضرتك انا فرحانه بيكي، وفعلا فعلا كلنا فرحانين بحضرتك ووجود حضرتك معانا. وفعلا يعني بحس كده الانتماء فعلا للبلد وحب البلد. يعني الواحد مهما بيبعد برضه بيرجع تاني. ووجود حضرتك كل سنه في المؤتمرات طبعا ده شرف كبير لينا ونستفيد من علم حضرتك. يعني اتفضلي حضرتك هتكلمينا الدكتوره ساميه عن الريسنت ادفانسد ان تريتنج سيستيك فايبروزس. اتفضلي حضرتك.
ألف شكر، ألف شكر على المقدمة الجميلة دي. والله أنا حاسة إن أنا بين أهلي يعني، فألف شكر. الله يخليك. الدكتورة إيمان طلبت مني أن أتكلم على العلاج بتاع السيستيك فايبروسيس. So this is I'm not going to focus too much in what we do now for CF. I'm going to also talk about the modulators that you're trying to get to the country. So we usually start when I have a newborn baby coming in, no respiratory symptoms whatsoever. I usually immediately start bronchodilator, which is a Ventolin that you have here, either nebulized or inhaler, either way is fine. And then we do airway clearance, and we do that twice a day. And it doesn't matter, the patient don't have any symptoms yet. So we usually tell the parents that I'm doing this to keep them keep their lungs clear, to make sure that the secretions are moved from the airways. The bronchodilator reason for using it is that you're trying to help the ciliary motion move the secretion from the lungs. So that's the first thing I usually do. Second, if the baby start having coughing, congestion, needing IV antibiotics, and we usually tell the parents if the patient is coughing for more than two days or 3 days to call us. And they call us, we tell them to increase the airway clearance and the albuterol to 4 times a day, and we give them antibiotics. We usually have culture results because we do the culture, throat culture every 3 months, or sputum culture, whichever. And then if they are needing antibiotics and starting to get sick, I start the mucolytic, which in the US we use the Dornase alpha, but here you can use the Mucomyst. I don't know if you're using Mucomyst nebulized or is it still the oral? Nebulized, perfect. And then the hypertonic I use after the mucolytic. The reason for that is that usually I don't have that much problems with the mucolytics. Doesn't cause a lot of cough. It's easier to use. It's once a day in my center. And then I use hypertonic after that. I start with that 7%. That's what was studied. And then I go down to the 3% if they cannot tolerate it. And we use that twice a day. If they start having any infections, I usually don't treat any like staph infections or Stenotrophomonas or things like that unless they have symptoms. But if they have Pseudomonas, any species of the Pseudomonas, usually I start inhaled tobramycin because we have it in the US. Here you can start with inhaled gentamicin. You can start with amikacin. We usually do it 28 days on, 28 days off because that's how the studies was done. Before the TOBI studies came, we were using gentamicin regularly, like we'd use it just twice a day regularly if they're chronically infected. And we use 40 milligram twice a day or 80 milligram, and we've used the injectable ones. But we have multitude of them now. We have the tobramycin, we have the aztreonam, we have the vancomycin. We're using vancomycin actually off-label. And then the colistin, we don't like it too much in the US. We just didn't do the studies. The product is nasty. I mean, if you have it here, use it. But in the US, we don't use it that much. We use it if we get stuck. So. And then anti-inflammatory is important. Some of the CF patients are asthmatic as well. So if they're proven to be asthmatics, then we use inhaled steroids. So I was asked earlier about if patients come in with having chest tightness and it looks like an asthma attack kind of thing, I would treat it as an asthma attack. I would treat it with steroids systemically. I start inhaled steroids. And if it looks like an infection, I start antibiotics as well. But that's kind of in a summary of what I do now for CF patients. So this is a slide that shows you anytime you talk about CF, you have to remember this cycle. So you have to remember that the defect starts at birth and it starts with a genetic defect, and that gets you to have, airway damage, you have thick secretions, you have airway infection, you have airway inflammation, and this cycle keeps going on and on. So what you're trying to do is you're trying to break the cycle. So for the loss of CFTR, which is the genetic defect, really the gene therapy is the one you need to have. But this has been going on since 1990, and I don't think we're close to phase 3 yet. We're still in phase 1. Studies usually go phase 1, 2, 3. Well, actually, there's pre-phase 1 and then 1, 2, 3. And before we use anything, it has to pass through phase 3. So right now we still are stuck in phase 1 or 1B, or yet, so still early. But we have the modulators. The modulators have been, so I wasn't too, so ivacaftor is amazing. But then we have the Orkambi or the lumicaftor, ivacaftor, not really that good. It's not worth the money. And then you have the Semdico, which was the 2nd generation modulator. I'll go over through all of these, but the Trikafta is the winner, is the best one ever. If you're going to invest money in any modulators, should be Trikafta. That's it. I'm just simplifying here. So there is a lot of patients that need extra, like they cannot qualify for the modulator, so you can use other things like the gene editing and RNA editing. And then you have the hydrator, they have the antimicrobial, we use antibiotics extensively, anti-inflammatory, and then you also have to follow them up to see, I mean, it was mentioned before by Dr. Hudud, he has patients that don't have respiratory symptoms or respiratory disease. I don't buy that. There is always respiratory disease. This is how they start. So if they have GI disease, that's fine, but most of them would have so you have to check. If you don't have symptoms, check it out. Do CT, do chest X-ray, do things to evaluate it. Older ones do spirometry. So all CF patients have to have respiratory disease. So now we'll go into like the long winding road of CF. So in 1989, we have the CF gene was identified. I wouldn't say discovered, I would say identified. And it was a very interesting time in CF. I actually was a fellow, started my fellowship at that time, and we went to the CF meeting, and it was an unbelievable change in the culture and in the reviewing the disease. So all of a sudden we have a lot of researchers joining us, and it became really a hot topic, if you will, for all the researchers to work on it. So in 1990, there was so they identified the gene in 1989, but then they thought there's only, that was a delta F508, and they thought there's only 1 or 2 mutations that they find after that. Since then, we have more than 2,000, and probably more even. So it's not an easy genetic disease, if you will, to investigate. Now we're having in 1990 till now, we're having the CFTR function and effect. Like we knew the mutation, but we didn't know what that does. So the way that we now understand it, it's a chloride channel, and it's in the cell surface, like I showed earlier. That was not happening at the beginning. That took time till we figured that out. Then after that, there was an attempt to modulate or to find some treatment for it. So this, again, the picture of the gene. So you can see this is the 2 membrane spanning domain. There are 6, but there are 2 of the sets of the 6 membrane spanning domain. And then there's the R domain, the nucleotide binding domain. Delta F508 is here. And this is how it's done. They're folded into each other, so they make the chloride channel. So when we talk about CF mutations now, we usually have to show the classes of the mutation. That makes a huge difference for us. So we have the first class is, this is the no CFTR made. This is the one that is created in the nucleus, and then it doesn't leave the nucleus. It just gets stuck here and die. This is the like the termination codons mutations, if you will. And these are the hardest to treat. Then the second one is the misfolding of the CFTR, and it fails to reach the surface. So you leave the nucleus, and you get here into the Golgi apparatus, and you kind of, it gets misfolded, so it's not folded correctly, and it does not go to the cell surface. So you need something to help it unfold and then go up to the cell surface. So that's the delta F508. The class 3 is easier. It goes to the cell surface, but it's weaker and it's not working correctly. It's kind of dysfunctional. So you have something just to help make it functional more. And then class 4 and 5 are similar in the classification. So you can see that the severity of the disease goes from phase 1, and then it goes easier or milder as you go down. So as I said, for class 2, you really need the, not only the corrector, but you need the potentiator. The potentiator was started with in class 3, and it extended to 4 and 5, and that's the ivacaftor, which is really a good modulator. So this one goes to, this is the CFTR and the class 3 that you can see. This is normal. It goes to the normal CFTR, goes to the cell surface. It opens and closes correctly. And then here it goes to the cell surface for class 3, but it then does not open and close correctly. So it just needs some extra help. And this slide just shows you the what the ivacaftor does. So this is the results of the ivacaftor, and it's, again, was very exciting at the time as well. And most of the Vertex studies, and I'm saying the name of the company because everybody knows, were really like a study that it comes to your center, multi-center studies, and you sign in quickly because there is so much competition. Patients know about it. Patients call you. You don't even call the patient to recruit them for studies. They call you and say, I know you're doing a study. I want to participate. That's because it was really, the value was unbelievable. So you can see the first one here is the sweat test. So we did the sweat test. This sweat test was around 100. Yep. And then when we did the ivacaftor, you can see that the sweat test went down to below diagnostic. So they were around 50 milliequivalent. With you like parents were coming to us and saying, do my kids still have CF? I was like, yes, because if you stop the ivacaftor, it will go up again. So, but it was very eye-opener. The second one is the FEV1, and it improved significantly by like 15%, 10 to 15%, and it stayed up. So it was very interesting that you kind of follow them for years, and they're still, their lung function is amazing. We looked at the any exacerbations, and you can see the exacerbation was a lot less than the ones that were controlled. And this one was a surprise for all of us, that we saw that the weight increased. So we didn't expect that. So patients that we've been having years, and these were all moderate patients, so they're having issues with weight gain, and then all of a sudden you're doing the ivacaftor and boom, they're gaining a lot of weight. So that was very exciting as well. So this one for the delta F508, which is the troublemaker. So you can see that, you know, they need, this is restructuring it, and then that, you know, you wanted to see how you can fix that, and you have to fix it with two different things. So you can see, like, it again, it goes into Golgi apparatus and goes the nucleus goes to a Golgi apparatus and gets some way misfolded here and doesn't go up to the surface. So you wanted to work on that. So what you wanted is a you know, because of the degradation, so you need a corrector. The corrector will help unfolding. So you're correcting the direction of the gene, if you will. And then you to reach the cell surface, and then when it reaches the cell surface, you're going to use the ivacaftor to help potentiate it, which is fine. We have not changed ivacaftor since they started. But then, so yeah, here is again the corrector and the potentiator, just to show you again. So the first study with the lumicaftor, ivacaftor. So again, very excited. All the CF population were very happy, and all the centers are excited about it. We didn't get that much benefit. So you can see here that the improvement, and the scale is kind of deceiving, but it's only 2% improvement. And then when it got the open label, so you got the placebo group started to have the drug, and in addition to the continuation of the people on the drug. And you can see that long-term, it went down to like almost 1%. So that's not really statistically significant. We did use it because we didn't have other options at the time. But a lot of my patients didn't want to do it. They want to wait for the next generation, and or they started it and didn't have benefits, so we stopped it. So after that, it came the second generation of corrector, and that's the tezacaftor. So lumicaftor wasn't that exciting. Then we moved on to tezacaftor. Well, tezacaftor was better. So, but you can see also the improvement was only about 3%, 4%. So we used it because it was better than nothing, if you will. But it's very expensive, better than nothing, to tell you the truth. So so here, this slide shows you comparison of what we're talking about. So here you have the ivacaftor. You can see the improvement, 10% in sustained. Then you can see the tezacaftor, ivacaftor. We didn't even put the lumicaftor, ivacaftor here. And then that's compared to placebo. So there was still a big gap in the care here. So that took us to the triple combination. If the two didn't work, then we make them 3. So we did so tezacaftor was okay, wasn't great, but it was okay. And then you have the elexacaftor. So they had elexacaftor, tezacaftor as correctors, and the potentiator was the ivacaftor. And these are 2 studies that were published. So they did it for homozygous delta F. The studies did it for homozygous delta F and for single delta F gene together. So they did the 2 studies were going parallel. So that way we can get the approval from the FDA and can see if there is benefit to get it together here. And this is the results. And sorry, the slide is not very clear, but I couldn't make it better. So, so you can see that the improvement in the FEV1 was up to 15%, even better than the ivacaftor. And then the reduction in the sweat test way down to 20%. You know, sometimes, but it's mainly 40, 50%. So it was amazing that the degree of the decrease in the both of them. We do quality improvement. Any study we do quality improvement for patients to see, are they feeling better with the drug? So any study we do, we usually have that. And there is a specific quality improvement survey that we use. And the quality improvement was amazing in using it right here. And then this one was mainly the BMI to see, did we also improve the weight? So, and yes, we did. So that was really amazing. And when you do a study and it shows good results, that doesn't mean that it will work as well in the patients. So real life experimentation with the drug is really what proved to me if it is good or not. And I have parents coming in when they see the lung function and we see the way they start crying. And, you know, I cried with some of them because it's like, we never were able to get the lung function better. And all of a sudden, with whatever they're doing, it increased by 20%, which is like unheard of. So the elexacaftor, tezacaftor, ivacaftor, a combination has been amazing. And it's approved by the FDA for all delta F508 single mutation or double mutations. So we use it like 90% of the patients are covered. So it's really very interesting. These drugs actually are approved quickly by the FDA because it's considered for an orphan disease. So when you're dealing with a disease that has not too many patients, the FDA have a process to speed up the approval. And that drug was approved for 12 and above, but you want to start it early. Actually, you want to start it at birth because that will help you like eliminate CF symptoms. But now we went down to 6 years of age. So actually we have it now approved in September 10th. And I remember the day that in 2020 where it was approved. September 10th was approved for the 12 and above. But this year in June 8th, and I also can tell you the date because of several reasons, June 8th of this year, we had the approval for 6 to 11-year-old. So now you can see the slide that I showed you earlier with the Trikafta. We don't know where it's going to end. The patients have been doing amazing. And when you started early, they will do better. So this is kind of show you when a patient tell me, well, you're going to run out of business. It's like, I know, because you have the moderate disease are not going to go away and the severe disease. So here, the ratio of the healthy patients is increasing, but there's still population that you need to take care of. So there are other companies that are trying to work on this. So hopefully they'll come up with something to make it to be more competitive. So here you can see just the short period of time that we went from no modulator to having the triple combination. And it all started in 2012. And then all of a sudden in 2019, we have the elixacaftor, tezacaftor. This, in the life of drug development, this is unheard of. So the speed of doing the studies and the speed of approval was unbelievable. So that's very important to keep in mind. So with all of that in the CF Foundation logo, it say, till no one is left behind. So we do have some patients left behind. We have about 10% of the patients that are, I'm almost done, so if you can keep me going for another minute. The 10% of the patients that are left, there is a lot of work doing for them. Can we move the slide? Okay. So the remaining challenges are mainly to be able to read through the gene and get a gene therapy going. So there is the RNA-based therapies that's going on right now, and the gene therapy that I said was still, I don't spend too much time in gene therapy because it's still early. And that's really important. There is a lot of work going in the gene therapy field, but still too early to talk about too much. And this slide is one of my favorite, and you can see that the survival of the CF patients increased tremendously. And every time there is a new discovery, there is improvement. And now we're having a straight line up. And that's what I really want to see in Egypt. I think we're in Egypt, we probably are around this point here. So I really want to see the improvement in the survival here. So we have long ways to go. And thank you. I don't think there's time for questions, right? Just
دكتورة سامية، لا ممكن نسأل سؤال واحد. يعني بشكرك حقيقة لأن الموضوع فعلا recent advances ويمكن هارد شوية، لكن يعني اللي طلعت بيه إن في حاجة approved اللي هو التريبل كومبينيشن، بس كل الدراسات عن cystic fibrosis as a disease. في systemic effects side effects للدراجز دي ولا لا؟
Oh, there is always, yeah.
There is always.
Yeah, always patients ask me. So there are some that we're aware of that they might have depression is actually listed there. They all get rash when they start the drug. Yeah. And it depends on how bad the rash is. A lot of them would have rash and they would say, no, we're continuing, we're not stopping. Some of them would have a lot of cough and a lot of mucus secretion. So they're coughing and bringing up stuff. These are patients that never really coughed up things before. All of a sudden, because it's clearing things in the lungs, so you have a lot of secretions coming up. Abdominal pain can happen. They might have diarrhea as well. It actually affects the GI system too. That's why the weight gain. So we usually alert the patient about the rash, the headaches, depression. I don't say depression too much because sometimes if they hear depression, they will just think that they have it. So I just keep it till they tell me that if they have issues. So but the rash, the cough, and the sputum.
Thanks production. A lot, Dr. Samya.
No problem.
Dr. Usam.
لما حضرتك بتتابع فولو اب للعيانين دلوقتي بتقولي ان من ضمن الساين اوف امبروفمنت ان السويكرايت تيست بتنزل، ازاي بقى نفهم دي مع بعضها؟
Right. So I always said that the sweat test value doesn't really matter for the clinical presentation, but for a study to prove effective for the FDA, you have to also do the sweat testing because it did affect it. So, and when you go from 100 to 50, most likely your symptoms are going to be milder too, because you're actually below the detective for the disease. So yeah, it does affect it. Yeah.
منطقي الحال ان السكرايت بتمثل باثولوجي. يعني هي بتمثل الباثولوجي بتاع السيستيك فايبروزس، فان الكلورايد ما بيطلعش، فهو معنى ان احس الباثولوجي نحس الكلينيكال بيكتشر.
Right. So in the stage that we're in Egypt, you really don't want to pay too much to the number. If it's above 6, if 60 and above, you're above 60. You're diagnostic. And then when we get to the modulator, we can talk.
هل ممكن نبتدي التوك اللي بعته عشان التايم؟ الدكتور طيب نص سؤال، ربع سؤال.
Thank you very much, Professor Samya, for this teaching lecture. What about the methylated DNA group for improvement of the downregulation of the CFTR?
Right. There is a lot of other studies going on, but to tell you the truth, it's not as advanced as the studies that we're doing now. But yeah, there was studies about this, but I don't think it's as active. I haven't seen phase 3 studies for that. So, right.
Okay, thank you. I have the pleasure to introduce Professor Dr. Samya Nasr, Professor of Pediatric Nutrition in Ain Shams University. ودي سيمفونية تانية للnutritional management and guideline in CF patients. ممكن الدكتورة مي تفضلي حضرتك.
السلام عليكم. I'm very happy to be with you today وشكرا للحضور وشكرا ان حضراتكم يعني مشاركينا يومنا العلمي الجميل. شكرا للمنصة الكريمة على التقديم. سعادتي لا توصف ان انا معاكم في المؤتمر هنا. شكرا للاستاذ الدكتور ايمان على الفكره العظيمه. شكرا استاذ دكتور ثروت انك خليت الفكره الجميله تبقى فعلا في حيز التطبيق. شكرا استاذ دكتور ايهاب الغائب الحاضر. شكرا لضيفتنا الاستاذه الدكتوره ساميه الحقيقه اسرتنا. وهستاذن حضراتكم ان احنا نسيب الفيوتشر بقى والامال الجميله ونيجي لارض الواقع شويه. انا هتكلم على المانجمنت من ناحيه الكلينيكال نيوتريشن. فاحنا هنمانج اللي قدامنا لغايه ما ربنا يكرمنا بالعلاجات وان شاء الله يخفوا وما يحتاجوناش تاني. التوك بتاعتي النهارده هتبقى العنوان بتاعها نيوتريشن